Right, well, good afternoon. So, I'm going to speak to you today after lunch, so try to fall asleep if you want to. Our topic about ocular complications, HIV. So it's a bit more pictorial more than anything else, right? So, again, it's one of these things where you have many types of complications. So it's impossible to cover everything. So I'm just going to run through quite quickly, just to give you a brief idea of what are possible things that you can possibly see, and at least raise an index of suspicion if you ever come across any patients similar. All right, so it's more pictorial. Some of the words you can sort of just gloss through them, just have a brief 1 or 2 points, and the rest just have a look at pictures. All right, let's get on with it. AIDS and HIV, I probably don't have to say very much. You know what AIDS stands for, acquired immune deficiency syndrome. HIV, a retrovirus, which is an RNA virus. That's HIV-1 and HIV-2, which is the major cause of AIDS in Southeast Asia. Treatment, well, at this point in time, the virus cannot be eliminated, so we can suppress the replication, but you can't eradicate. Very similar to herpes virus and such. Just a quick note, we'll mention it again in more detail. HAART therapy, which is highly active antiretroviral therapy. Generally, it's a combination of a few different types of classes of drugs, and that's been shown to be the most effective in suppression replication. That we need to talk about, when you talk about treatment, we have to talk about not just the HIV itself, you have to treat whatever complication that you may be seeing, and finally talk about prophylaxis and prevention, especially in the early stages of the disease where the immune system is low. Right? So some of the common prophylaxis that you may see in these patients may include that for PCP, pneumocystis carinii, toxoplasma, TB, and atypical mycobacterium. So, like I mentioned, there are so many drugs these days. It's almost like biologics. It just increases with every year, every month. You see new things coming up. Well, maybe not every month, but certainly very frequent. But long and short of it, there are a few classes, different types. In the early days, we have these nucleoside reverse transcriptase inhibitors, non-nucleoside reverse transcriptase inhibitors, and the protease inhibitors. These three were the initial ones, and if you pick one of each category or more, then that's considered highly antiretroviral therapy. Now, prior to these three, they will be treated with only 2 drugs, and that's called antiretroviral therapy, and they were not as effective. All right? So when it came out with these 3, including the protease inhibitors, and that's considered HAART therapy. So nowadays, in addition to all these, you have integrase inhibitors and some newer ones, chemokine antagonists and early inhibitors, preventing the HIV entering the CD4 cells, binding to the receptors. So these are newer drugs that you even see in the market. So sometimes when they come to you with a whole bunch of medication, you wonder what the hell are these? Well, these are what they are. Some of the more common ones that we may see, abacavir, lamivudine 3-TC, these are common, tenofovir, efavirenz, entazanavir, darunavir. These are some of the more common ones already in the market, and some of them come in combination, especially Calitra, as the morning after tablet. In case those who don't know, for those highly active at risk, that's the tablet that they take, Calitra. Anyway, total CD4 count still remains the main predictor parameter for the occurrence of some specific disease. If the HIV CD4 count is below certain counts, you expect, all right, some kind of disease is more likely to happen. However, for an ID physician, CD4 count is kind of passé. They all do look at viral load, all right, and that tells you, determine the effectiveness of their therapy. But we don't really have a correlation between viral load and predictor of what kind of complications yet. Okay, sorry about that. Good God. Okay, so undetected viral load for an ID physician is what they're really looking for. That shows very low multiplication of the virus. Okay, so early complications are correlating with various stages. Various type levels of CD4 counts, you kind of expect different types of diseases. The long and short of it is, when you have a CD4 count of less than 200, you're really quite immunocompromised. That's when you see all your opportunistic infections and tumors. All right. When it's 200 to 500, you also see other things happening, including ocular TV, lymphoma, herpes. Now, this is not obviously not hard and fast rule, but it kind of gives you a rough idea. Okay, you're below 500 now. What are the kind of things that you may be expecting? Alarm bells start going up. Again, just to show you, more than 500, some of the more common ones. Less than 200 or less than 100. Highlight in red, CFV retinitis is still by far one of the most common infections you will see, and you may still see coming to you with progressive loss of vision. Now, briefly, HIV in the eye or AIDS in the eye can be divided into 5 different categories. And remember, actually up to almost 3/4 of patients will have some problem in their eyes, mild to severe or otherwise. Vasculopathy, or especially HIV retinopathy, complicating infections, which are a whole bunch, I'll go through them, tumors, neuroophthalmic manifestations, and complication of treatment. So broadly, there are these 5 problems that you will see in regards to AIDS and the eye. So now we're going to pictures now, words over HIV vasculopathy or HIV retinopathy. This is what you kind of see, multiple cotton wool spots. So you look at the eye, HIV patient, non-diabetic and non-hypertension, you see multiple cotton wool spots, that's HIV retinopathy. This is a form of vasculopathy. It's actually one of the most common retinal pathology. Of course, again, with heart therapy, you see less of it. These are actually cotton wool spots, very transient. They will fade and disappear in about 1 to 2 months. So the next time you see them, they may be gone, and that's very consistent with HIV retinopathy. Tiny little things, and they are still cotton wool spots, so they actually represent arteriolar occlusions, an interruption of exoplasmic flow, pretty much like what cotton wool spot you see in, say, diabetic retinopathy. Sometimes, if you look at it, you're not quite sure, they can actually look or mimic like very early CFV retinitis or PCP retinopathy. So this is what HIV retinopathy is. Usually visually insignificant, but still may have some structural damage, especially of course if it occurs right in the center of your foveal macular area. Decreased vision is actually very uncommon, less than 3%. Is obviously related to severity and location of it. Abnormal visual fields is actually not that uncommon. They do represent arteriolar occlusion, so you may still see patchy defects on a visual field assessment. Decrease in contrast, about 10% of patients. They don't not only occur on the retina, they can also occur on the conjunctiva, and you see them as segmental dilatation, microaneurysms of the vessels, about 3/4 of the patients, and then what kind of things you kind of see, little spot telangiectatic, inverted commas, vessels, and these are what they actually are, all right, conjunctival vasculopathy. So again, can be not uncommon. All right, let's talk quickly about tumors. What do you think this would be? A little subconch hemorrhage over there, subconch hemorrhage over there. Of course, if I tell you it can occur at the lids as well, then that's obviously a bit more common. If this is Kaposi sarcoma, just have to bear in mind, inferior conjunctiva is actually more common than the superior, and it can, if it appears on the lid, it's a little more obvious. So just be careful if what looks like subconch hemorrhage or is recurrent, is persistent in a patient with HIV, they can actually be Kaposi sarcoma, right? So this is just another picture, one of my local patients with a big lesion on the lower lid. So that's Kaposi sarcoma over there. I will quickly just go through that. Once in red, HHV-H virus, and it's actually a tumor arising from the mesenchymal tissue of lymphatic endothelium. It used to be one of the MCQ type questions. Lymphatic endothelium, that's what it is, not blood vessel endothelium, right? And actually, they fill with the blood cells, so they look red. Occurs in 25%. Most commonly eyelids, conjunctiva. It's actually not curable per se, but you can palliate it with cryo. Let's see, you get these problems. It's a local Wi-Fi. Not curable, palliated. All right, so tiny ones, you can actually, there are many ways people have tried intralesional interferons and chemotherapy, or you can excise them if it's small enough. Right? In 40% or more, they can actually resolve when you start heart therapy. Just to show you that actually with heart therapy, the incidence has plummeted not common at all. If you see somebody with Kaposi sarcoma that either A, not on treatment, not compliant treatment, or they failed therapy, basically. Other conjunctival neoplasias, CIN, carcinoma in situ, may mimic an inflamed pinguiculum, again a persistent inflamed pinguiculum. SCC, squamous cell, they get very irregular features with some hemorrhage. That's SCC, and conjunctival lymphoma, which is typically a bit of a salmon patch lesion. AIDS lymphoma is actually the second most common CNS cause of CNS mass. Not common at all, most commonly EBV related. These are just to show you a patient with what started with a CNS lymphoma in a HIV patient, subsequently developed these big yellowish mass, subretinal mass behind the retinas that became a retroretinal lymphoma, an intraocular lymphoma. Okay, opportunistic infections, intraocular inflammation. Inflammation can be divided again broadly: infectious, non-infectious. So infectious, we'll go through that again. Non-infectious includes the vasculopathy, drug-related inflammation, and non-infectious, such as that related to treatment, which I'll briefly mention again later on immune recovery uveitis. Infectious, of course, there are many, CMV retinitis being at the top of the list, which I'll go through in a bit more in detail. All right, multiple nodules with a little umbilicated, a little central depression, usually painless. What would that be? Usually seen in kids, really. Molluscum. So again, an adult showing up with molluscum, be really, really careful. This patient should be immunocompromised. You know, this is typically a disease of kids, children. So if you see bilateral, multiple, adult, be very careful. Most common, highly contagious, pox virus. Well, this is obviously a lesion that you would recognize immediately. HSO, obviously, in HIV, they will tend to be more fulminant. The appearance is your typical HSO, except a lot more fulminant, aggressive looking, right? But otherwise, you can use it respects the usual midline, usual dermatomal distribution, and of course can spread to the cornea and the surface. So HSO, about 10%. Interestingly enough, the incidence does not seem to have decreased even with heart therapy, so it still happens and lingers around. Usually if your CD4 is less than 200, again, less than 200, complications goes up. Of these, HIV corneal inflammation infection is actually not so common, less than 5%, but of course can affect vision permanently. Right? And what about retinitis after zoster? Again, about 10%, 15% may occur, so things to look out for. Right. Whitish lesion on the retina. This is next to the disc, and do a scan, you see this ring lesions. It's kind of classic of toxoplasmosis. So again, multiple lesions, ring lesions in the head. All these are very common presentations of cerebral toxoplasmosis and ocular toxoplasmosis. Not any pretty much different from what you see in standard patients with toxoplasmosis, all right? Just could be a little more aggressive in their progression. This is now starting to get more whitish things in the back of the eye. So what you notice now is I'm presenting lots of white things. It really can be anything. So that's one point to note. A lot of these lesions may come with infections. They may come with just a lot of white stuff in the back of the eye, and you just have to go around investigations, go down the list, what does it look like, and investigate from there. All right, so we have a lesion over there, whitish thing. I'll tell you just by looking at it, you can't tell what it is. I mean, just be honest with it. You look at it, you can't tell. You know this is a choroiditis lesion, chororetinopathy. You can see a bit of humping of the retinal thickening over there on the OCT, but that's all there is to it. I'll tell you first on investigation, you'll find there's cryptococcosis, but just by looking at that, you cannot possibly say this is cryptococcosis. All right? You investigate it, certainly you can find out what they have, you can do the blood test, and something will show up. It can present many ways, not just a choroiditis, it can have exudative detachments. You can see over there, the OCT. Again, everything is less common in the heart era. but most commonly they have cryptoglocosis of the eye. Of course, they have it in their bloodstream as well. That's why you can do it on a blood test. Usually it's systemic dissemination. Papilledema with optic atrophy is the most common presentation of the cryptoglocosis. And there is one typical way, description of cryptococcus infection, which is the champagne cork. If you look in, they get this massive papilledema, really, really, really protruding out at you, and that's the typical appearance of that cryptococcus. And HIV, you see this thing bulging up at you, this swelling, it's really bulging, highly suspect that this is cryptococcus infection. And of course, like all papilledema, you'll end up with the optic atrophy. Ocular syphilis, like all syphilis, honestly again, will present in any way. Hand uveitis, optic disc swelling, posterior uveitis, CMO, pretty much like any other patient with ocular syphilis. Placoid lesions. So, like I mentioned here, anterior intermediate optic choroidal anything, all right? Non-necrotizing retinitis, in the end, you may get this kind of a, well, I would say a bit of stipple hyperpigmentation, similar to a bit like your salt and pepper kind of appearance. Relapse is more common in HIV patients. Treatment is like with any neurosyphilis regimen. So again, once you have an infection in the eye, you just have to go down the whole list of the common presentations and then investigate and determine what it is. Whitish, more white stuff in the back of the eye, round little lesions over there. Sorry, it's a bit dark on this photograph. But on the other hand, this looks rather well defined, not much inflammation. This one will be pneumocystis. Alright, so just showing you again the lesions on the FFA, that's what they look like. They don't seem to leak very much, it's sort of just a bit of a filling kind of defect. Over here, nothing very much, stains a bit. So pneumocystis is a really now classified as a unicellular fungus, really found in the lungs of healthy and airborne. It used to be very, very common, and the prophylaxis used to be aerosolized pentamidine, which nowadays, if you change, you see most patients will be taking oral Bactrim, and the control is a lot better. All right, so probably don't see so much of this again. Less than 200 again, CD4. Of course, you get a pneumocystis, pneumonia. You actually have a 10% mortality in HIV patients. The choroidopathy. Rare, all right, so I mean that's probably the most common thing you just have to remember. Little white lesions don't look very active, they look very quiet, multiple small little lesions. The thing of pneumocystis, again, investigation shot quite easily. Here this huge study of the HIV population without CFE retinitis, 3 of 3,000 patients developed pneumocystis choroidopathy, so it's really quite uncommon. So clinical features, deep, brown, yellow, multiple usually, about 1 diameter, up to 1 diameter, usually bilateral. No retinal vasculitis, no vitritis, so quite quiet. FA, just a bit of late staining. Right. So this one, the next one, so the slides got a bit reversed. That was actually just showing the cross-section view of a patient with this, which is mycobacterium. You can see the choroidal lesions over there. Again, whitish lesions in the back of the eye. The only difference between this one and the earlier one is if you could see that this one, the eye edges look a bit more feathery, a bit more fluffy, not as well defined looking. Of course, this one has a bit more inflammation on the vitreous as well. So all whitish lesions. So TB, syphilis, all these are always differentials of any uveitis, posterior uveitis that you may see, even in your standard non-HIV patients. Candida, patient comes in with a flurry tongue over there, or some of them may get thrush, oral thrush. You see whitish lesions, snowball lesions inferiorly, a bit of a haze. Think of fungal infection or candida. This is, again, these are tiny choroidal lesions, smaller ones, a bit fluffy looking. That's actually candida as well. Fungal keratitis, Other fungal organisms include Fusarium, Aspergillus. So in developing countries, if you actually get a fungal keratitis, just be wary. It could be also represent an HIV infection. Of course, if you're working in the fields, in the farm, it could have caught it from those kind of areas. If you're not, then beware. It could also be a indicator for HIV or immunocompromise. So differentials are many. It's impossible to tell you which one is which. Some of them may have some characteristic lesions, appearance, but most of them are just white-looking stuff in the back of the eye, which is classic of uveitis, cells, and go figure out what it's due to. But as a rough rule, you have choroiditis, you have a whole list of things: tuberculosis, cryptococcus, pneumocystis, syphilis, Candida. Again, the list is not exhaustible, but these are some of the common ones. If you have retinitis, think of the herpes family before anything else. You have herpes, HRCV, ZV, CMV, it can also be syphilis as well. So these are just broadly, if you sort of eyeball it, what kind of lesions you see that may point you towards how you want to investigate, right? So remember, having said all that, remember one point. These are immunocompromised patients, and can be more than one. Okay? Yes, it may look like one lesion, but not uncommonly something will catch you off guard. There may be more than one infection going on at the same time. Right, infections. This is the back of the eye, one whole big lesion in the back, in a mass, in the nasal sinuses, infiltrating into the orbit itself. That's orbital aspergillosis, no different from, again, a healthy individual suddenly the orbital aspergillosis, not healthy, but typically not in non-HIV, the typical patient will be one with a poorly controlled diabetes. Seen all over really, aspergillus, one of the most severe is of fungal infections. Aspergillus is one of the most common as well. But again, despite immunosuppression, very immunosuppressed patients, you don't actually see so many of these aspergillosis around. And of course, these again can happen in healthy individuals when there's a red eye, not a sore eye, with little punctate keratitis on the surface of the eye. Looks like a bit of a redness of the conjunctiva at the bottom. This can typically occur in any healthy patient who has been in the fields, especially your rugby players. This can also be seen in HIV patients, microsporidium. All right. No complication, not just in healthy rugby players. Again, the only difference is that they may actually resolve with your heart therapy without any specific antimicrobial therapy. So again, if you improve their state, some of these will clear away by themselves. All right, just a point, a 38-year-old man, eye screening because the CD4 was less than 20 and was found to have less CMV retinitis. He's really a diabetic as well, non-compliant. He also has presumptive PCP, pneumonia, on back trip, on antiretroviral therapy. He was initially treated with ganciclovir, responded well to the heart therapy, and the CD4 improved from less than 20 to 164. Developed immune recovery uveitis, was treated with Predfort, doing very well. So everything seems to be fine and dandy, treated very well. Complaints of a mild painless or blurring of vision. This is the OCT. The vision in the right eye was 6/12. Something's going on, but nothing really seen. OCT was fine. 2 months later, that vision became hand movements. OCT seems to be flattening out over there. Oops, sorry. And that's the fundus image. Sorry about that, a bit hazy, but never mind that image. What I just want to point out to you, this was the MRI, that was the lesion. Okay? So, this patient has a HIV, CMV redness, recovery uveitis, CD4s responded well, the CMV redness responded well, then why is the vision dropping? So finally, get the MRI, and that revealed the diagnosis. This is a meningioma. HIV-associated meningiomas can, and of course, occur in otherwise normal, young, healthy, middle-aged men. in a context of an HIV patient, it may actually develop from a loss of immune function or a dysregulation of the cytokines. A balance of the Th1 and Th2 cytokines is thought to be the main factor for prognosis. So again, this is just showing a point that your patient may be doing very well, but something else may also be happening at the same time. All right? In this case, not just an infection, they can also get a tumor, in this case a meningioma. What other neuroophthalmic manifestations? Well, about 10% of the patients will have something. We have mentioned about meningitis and cryptococcus and champagne cork appearance with raised papilledema, lymphomas. We've also briefly mentioned that, neurosyphilis, cerebral toxoplasmosis, and superimposed with the polyomavirus is PML, or progressive multifocal leukoencephalopathy. Now, so briefly we mentioned all that. Let's just concentrate a little bit more on CMV retinitis. So we already mentioned it's quite common, and the most common visual threatening infection in the back of the eye is actually CMV retinitis, and used to be the most common opportunity infection, especially your CD4 is less than 50. 3/4 of your CMV diseases, it represents 3/4 of your CMV diseases seen in AIDS patients, right? Potentially blinding. Now bear in mind, like all retinitis, they're often asymptomatic until the macula or the optic nerve is involved. In the early stages, CMV retinitis does not generate big uveitic response. You don't see much vitritis, so they may not actually even complain of haze or blurring or floaters. Vision's perfectly fine until it starts involving the macula. You will get your visual field defect, you will get a blurring of vision, which means it's imminently threatening the optic disc or the macula. Floaters, sometimes, but most of the time, it's a painless loss of vision. Briefly, we have described zone 1, zone 2, and zone 3, very, very similar to an ROB kind of description. Right? Zone 1 is within 3,000 microns from the center of the optic disc and the fovea, so this is a dumbbell shape. Zone 2 is outside the dumbbell shape to the equator, the ampulla of the vortex, and then zone 3 is beyond that. Overall rate of progression is actually quite slow. This is kind of thing you want to know. About 150 microns a week. All right, so the progression is actually not that big. So consider that the optic disc is about 1,005, so it's about 110 a week. So it can slowly progress over time, and it can be there. By the time you see it, it probably has been there for quite a while. So this is probably the typical appearance of a CMV retinitis. Looking at this, it cannot be mistaken for anything else really. That's your standard cheese and ketchup or pizza appearance. So you have all the vasculitis over there with the frosted bronchitis. You have your big retinitis, which is typically yellowish in appearance, and of course the hemorrhage along the blood vessels, giving your ketchup appearance. More pictures of CMV retinitis, more yellow and red. This is more red and yellow, and all of these appearances. This one, you can see that retinitis along here, they typically follow blood vessels. Back over here, yes, you can see this is a bit grayish. That's probably a treated, partially treated CMV retinitis. Again, more ketchup and cheese. This is a patient with bilateral disease. This is starting to affect the macula, so the vision will drop. And this big lesions over here can be in the periphery, but the macula hasn't been involved yet. Surprisingly, sometimes the vision still can be quite good. Doesn't have to be always so obvious. Can be a small little lesion up there. And this patient will have good vision. If something's kind of blocking at the bottom, a bit of visual field defect, that's your CMV retinitis. This is obvious. This is obvious, a big appearance of the yellowish lesion. So again, these are just running through pictures. After this, you should look at one of these and say that's CMV retinitis. All right, causes of visual loss, mainly where it is. If it's in the zone 1, next to the disc, next to the macula, and about 60% of them will have poor vision. All right, they can also develop cataract subsequent to that. Cystoid macular edema, not so common. About 15% will lose vision because of detachments eventually. Treatment, you treat until the immune reconstitute, usually that's with the ARV or therapy. Remember that all CMV therapies are virostatic, and the specific anti-CMV therapy can be local, such as intravitreal injections or sustained release implants, which is kind of outmoded now. Systemic will be oral or intravenous. So we have an implant called Vitracid, but Vitracid is no longer really in circulation. That's kind of also, I think it'd be hard pressed to find one. Maybe if you go through some orphan drug, you may go find a few left over for you. Ganciclovir can be given intravenous, intravitreal. It's commonly called cyclovine. Valganciclovir, Valsite is oral preparation. Foscarnet, given intravitreal, intravenous, or Foscavir. So these are what it kind of looks like. That's Ganciclovir in a bottle. Foscarnet is a big bottle, and that's what it used to look like a Vitracid implant, which is implanted into a pars plana like so, with a strap over here, stitched to the outside of the eye. So the drug, this is a little reservoir over here that slowly releases the ganciclovir into the eye over a period of time. So I'll just quickly go through this one. Valganciclovir currently is probably the drug of choice for the treatment of CMV retinitis. It's convenient, you just pop a pill. Of course, you have to monitor your blood's renal function. You have no complaint of any intravenous lines, because in the days gone by where there was no oral preparation, patients will be having an intravenous line for the next few weeks, or they have to transfer to a PICC line because they need to administer ganciclovir twice a day for the next couple of weeks. Cost is, however, the major limiting factor. It's ridiculously expensive. It still is, and until they come up with something cheaper, that still remains the main hurdle, and of course availability of the drug in some places. It's really a very ester of ganciclovir that has an increased bioavailability of more than 10 times compared to oral ganciclovir. There used to be an oral ganciclovir, but the bioavailability was really, really very poor. With oral ganciclovir, is there any role for intravitreal? Well, yes. It can also be used for initial primary treatment if the patient is intolerant to any systemic treatment for any reason. Contraindications to systemic treatment, whether their bloods are really poor, kidneys are crap, other modalities such as implants, the drug available, or as an adjunct to the systemic medication, especially if we present with something very aggressive. If it's something within zone 1, of course, arguably you can say, all right, fine, I'll just treat with the oral first and see how well it goes. But you know how these antibiotics, antivirals work against bugs. It's a matter of a war. It's really who wins first. Whether you can suppress the virus or suppress the bacteria fast enough while they're still replicating, because it's already a foothold on the organ, or which means any other extension within zone 1 would creep into your macula or stroke optic nerve. And of course, you want to give them the best possible chance. You can give them an intravitreal injection, because that increases the drug concentration a lot within the eye itself. So sight-threatening, where it's affecting the fovea disc, or do something with the ARN in immunocompromised patients. Intravitreal, you know the advantages is basically gives a very high concentration beyond MIC compared to oral medication or systemic medication. So just to show you what happens after you treat this, this is what you look like. Right? So this is the same patient before and after. So the appearance is really, really different. Of course, if you look carefully, this part here is all kind of atrophic and kind of grayish. Once you have a retinitis that settles down, that area is atrophic. Right? Unless it's really early and just mild edema, then maybe you have some function left. But generally speaking, they're gone. There's no function left, but at least that's what it kind of looks like at the end of treatment. Retinal detachments, quickly just to mention, it's actually quite common in CMV retinitis. High incidence of bilateral treatment really is a vitrectomy, endolaser, and usually they end up with silicone oil with or without an Ensler clutch. Most surgeons will say their reattachment rate is about 3/4, 30 to 35%. Mean post-operative visual acuity, if you treat them early, if the macula is not involved, is about 680 plus minus. But one of the more important takeaway messages, prophylactic laser. Some people think, all right, fine, if you have detachment in one eye, let's do prophylactic laser on the other side, especially with CMV retinitis. Well, it does nothing really. All right, so if you're going to detach, you're still going to detach. Makes sense. Right? You're going to have a hole somewhere. The laser really depends on where the hole is going to develop. So CMV outcomes in the era of highly active antiretroviral therapy, you basically should show you that in a pre-heart era, the incidence is really high. After the heart era, RD, second eye involvement, progression of retinitis, basically all very, very low. All right, just some examples again. A 60-year-old man diagnosed with CMV in December and was treated with a standard 3-drug regimen. CD4 at that time, 1 year later was about, 1 month later, that was 280. Now he complains of blurring of vision for 2 weeks, and this is what you kind of see. You can see a whitish thing in the background, over here, maybe a hint of a reddish thing over there. All right, and this is not because the camera is smudgy. This is a real picture. Okay, so this is actually CMV retinitis with IRV. So what I just want to show you here, if you look at this picture, something doesn't add up completely. If this patient has HIV, and this looks like a CMV, there's too much vitritis. All right? They typically do not have much vitritis in a HIV patient. All right, most CMV retinitis patients, they're already quite immunocompromised. They should not see so much vitritis. So in this case, the reason for the vitritis was because he has got immune recovery uveitis. So long and short of it is, he has HIV. He was never checked for the eye, but there was already CMV retinitis going on. Started on ARV treatment, which he responded extremely well. He's one of these super responders that you treat and suddenly the CD4 goes back up. Immune system comes back online. CMV raging on in the eye, body reacts to it. That's immune recovery uveitis. So in this patient, he was treated at that time with immediately at that time with intravitreal ganciclovir first, and he was given oral prednisolone as well. Like all inflammation, you need steroids, you need anti-inflammatory medication. So what is IRU, or immune recovery uveitis? In this case, usually we talk about HIV patients. Usually you're referring to a patient with a previous CMV retinitis and currently possibly inactive, up to 60% of them. They must be on heart therapy and they must have immune reconstitution as indicated by elevated CD4 counts. Right? So you see a patient, presumably quite low, responded quite well, 280 within a month or two. He was on heart therapy, he has HIV, well, he has HIV, CMV retinitis that was not checked. All right? And intraocular inflammation is not accounted for anything else by other opportunistic infection or drug. So IRU typically presents with inflammation, especially in the back, in the vitreous. So it typically appears more vitritis than anterior uveitis. Right? If you do have anterior uveitis, usually flare cells, maybe up to about 2 plus. You will not typically see a hypopian uveitis, that kind of thing. Right? Usually it occurs after heart therapy. It will parallel the rise in the CD4 of more than 100 above the normal, what he started with. We'll just look at the bottom part, the risk factors for the severity of IRV, the degree of immune reconstitution. How fast are they responding? All right, so they respond very quickly to the ARV treatment. Good for the body, bad for the eye. If they have CMV retinitis. You have low initial CD4 counts, extent of the CMV retinitis, so the bigger an area of CMV retinitis, the more likely you're going to get problems. Well, that kind of probably reflects the amount of CMV antigen or the viral load that's in the eye. Right? So if you have a bigger load, conceivably bigger inflammation. If you have shorter course of treatment prior, if you have received heart therapy too quickly after CMV retinitis, if you treat it with cidofovir, your risk is higher as well, which fortunately we don't treat most of them with. Just to show you that if you immune recovery uveitis, if the lesion is actually more than 25%, you actually have a 2.5 times higher risk of immune recovery uveitis. Fortunately, we don't use so much cidofovir these days. It's pretty much quite restricted. I've only used it maybe once or twice in pediatric, where their hands are tied, again, cyclovir-resistant foscarnet has problems, and they had to use cidofovir. So, but you know, we gave it with this very gingerly, hoping that they don't get immune recovery uveitis. CMO and ERM is common, like any other uveitis. Posterior uveitis, CMO is not uncommon. Almost about half of the patients may have CMO after that. I don't have to go through the complications. IRV, they are really the standard complications of any posterior uveitis. Right? And you can get cystic edema, ERMs, cataract, VMT, TRD, etc., etc., etc. So, what about immune recovery that you need to remember? First, all newly diagnosed CMV retinitis should be treated with anti-CMV treatment. All right, so if you see it, you got to treat it. If you're heart naive, you have not been treated with ARV treatment, please consider delivering your anti-retinal therapy after the CMV is controlled. All right, and it must continue subsequently until everything is settled down. If you have immune recovery, continue treating with anti-CMV first until your CD4 comes up. Right, so basically, if you see somebody with CMV retinitis, you have also, you know you're HIV positive, untreated, you need to actually discuss very closely with the infectious disease physician. Why? As far as they are concerned, they need to get the CD4 up. They need to reduce the viral load. That saves life. But you have a CMV retinitis, a big patch of CMV retinitis in the eye, you know that if it starts as ARV too soon, you will run into problems with uveitis and you will lose eye. So you got to find a balance somewhere before you probably discuss them. Look, can I start treatment first with anti-CMV treatment, maybe for another 2 or 3 weeks, tie them over, maintain them, support them, make sure they don't get additional opportunistic infections and die from that. And if they survive during this 3 weeks, they can quickly start their ARV treatment. You have already reduced your viral load count. That reduces your chance of getting immune recovery uveitis, right? So that's something to bear in mind. And the other thing to have to discuss with them is that if they find somebody with newly diagnosed HIV and their CD4 count is really low, less than 100, you need to try to convince them to say, could you send them over to me first to look at the eye before you start your ARV? All right, remember, CMV retinitis in the periphery, no symptoms. Vision's perfect, could be 6/6, big patch of retinitis in the periphery, start ARV, problems for you. Final slide, intraocular inflammation is not uncommon, right? You have to think of infection, non-infections. But all these inflammations in the eye, especially in HIV, consider infectious until proven otherwise. CMV is probably the most common, but again, consider other pathologies, especially you don't see a retinitis. And again, consider multibacterial. You don't necessarily only have one. You could have more than one bug that's going on. And in the face of heart therapy, there will be a greater incidence of immune recovery uveitis. And remember, HIV doesn't equate to CMV retinitis, which a lot of ID physicians seem to think so. So you could have a lot of other manifestations that were mentioned earlier, other infections, non-inflammations, tumors, and as such. Thank you.
Can I ask a question?
Yes.
So this is a commonly encountered scenario when we're seeing blue letters in the ward.
Yes.
You come across just this patient who's been sent to you for routine CMV retinitis screening before they start the antiretrovirus. Then you see a few lesions over there that look like maybe it's early CMV retinitis. You know whether it's just HIV retinopathy.
Right.
And then the plan by the uveitis team is watch to see if, because that's one of the things.
Remember, CMV retinitis will progress, HIV retinopathy will disappear.
Correct.
So you don't have to wait too long.
Uh-huh.
If you say 2 weeks or within 2 weeks, two to 3 weeks, you will know.
All right. So will
if it's CMV, it will get bigger. So fundus, serial fundus photography will be very useful.
Right.
All right. If it disappears, you know it's HIV retinopathy. Please carry on whatever you want to do. If it's suspect, well, let's monitor. All being said, having if it is CMV retinitis, and if it's just one small spot, then probably not so bad because the viral load is probably quite low. So suppose you missed it and they already started and this turns out to be CMV, you probably can still treat it, but because the viral load is quite low, chances that you probably won't end up with such a bad uveitic problem.
All right. So to summarize, you will probably tell them to just let you watch for 2 to 3 weeks before starting.
They're comfortable sitting on it for 2 or 3 weeks. Okay. If they say really you have to, because there are other pressing systemic benefits, like Liza is going to die if you start, then fine, start. I will continue to monitor, but just watch very closely over the next 2 or 3 weeks.
Okay, thank you.
So it's all a matter of discussion with the ID physician and coming down to a amicable consensus.
Yeah. For immunorecovery uveitis, the treatment will be on the prednisolone and also the gemcitabine. May I know the preference route of administration for the prednisolone? I mean for the steroid, is it either oral, intravitreal, or topical? Oral. Okay. How about the gemcitabine?
If anything.
Do we need to add IV?
Not necessary. You can give oral Valcyclovir, Valcyclovir, it's fine. Whatever is available.
Intravitreal also.
Fine if you if you can't afford, don't have, you can still give intravitreal.
Or we give both.
Yeah, you have to give both. I mean, sorry, you mean 2 kinds of anti-CMV?
No, I mean, do we give intravitreal plus IV or we just choose either one?
I just choose one.
Okay, sorry, a couple of questions. With regards to the that point about starting anti-CMV, getting the CMV retinitis under control before the heart therapy is initiated, does the area of retinitis change in decision? Meaning, if you get a small patch in the periphery, maybe about less than 25%, would you necessarily say hold off heart therapy? Or
right, so that's similar to the same question earlier on. So if really a tiny one, you could say, all right, treat and balance out and see how far they can wait. But preferably if they can wait, you wait 2 or 3 weeks. By and large, if you have a tiny lesion and you start Valcyclovir today, within 3 weeks, generally you see a lot of quite a bit of response, probably quietening down already. So if they can wait, you wait 3 weeks. If they must, then well, if it's a tiny spot, less than 25%, all right, fine, just do it and fingers crossed.
And can I just ask also about the maintenance therapy? So from what I understand from what I was taught last time, actually by yourself, in Tan saying, you treat the patients with maintenance against cyclovir until the CD4 count recovers. But we do have instances where patients with HIV never do recover good CD4 count, or they take months or a patient may take to a year to recover CD4 more than 100. So in these kind of scenarios, do you keep hitting them every week with intravitreal, or do you take them on oral Valgan?
Yeah, yes.
So you continue on?
Yes.
And with regards to the IRU, you showed a case where there's very diffuse vitreous haze, but I've had cases where they just have very mild swelling, not much systemic macular edema, which is quite quiet, and it just rumbles on with just topical prep for. How aggressively do you treat these cases in the sense that persistent swelling, if the fear is you leave it there for months, something will happen down the road.
Is there any contraindications of oral?
But the fear of oral. So in that case, that patient the CD4 count hadn't recovered. So the fear always was, if I start oral, then will I reactivate his CMV?
You can always consider simultaneous therapy.
So, but we talk about simultaneous therapy. So the patient is also on oral Valgan cyclovir.
Then that's not a problem.
That should be alright.
Oh, yeah. If it's running on Valgan cyclovir, you can give very little Basically, I don't think the risk of it giving a problem is not high. Never say never, there will always be an exception, but if you're already on the maintenance valve cyclovir at that point in time, and you see all these complications of chronic uveitis, as it were, then I would not hesitate to put them on oral. After, you can always ask the ID physician, do you have any contraindications to starting oral? Most of the pain times I encounter, the answer is no. So yeah, I will start 0.5 milligram per kilogram if necessary. Higher if you have to.
Sorry, and one last question. We also have issues with patients with CMV retinitis in non-HIV immunocompromised states.
Right.
So recently I had a patient with multiple myeloma, had CMV retinitis a year ago. I treated him, he got better.
Right.
And then I was watching a few months, and then suddenly out of the blue, his ugly patch came up, and his CMV in the blood came positive.
Yes.
So would you have any tips about how you would monitor the level of, because I asked the level of immunosuppression for this patient, how would you monitor?
Nobody will give you an answer. Nobody can give you the answer. So similar, you have given one example, leukemia is the other one, post-transplants are the other ones, where they have had bone marrow transplantation and radiation, that sort of thing. So the only thing you ask them, well, how good or how bad is their immune status? The answer is not really, I don't really know the blood counts, the white blood cells don't say anything. The only indicator may be, and I say may because it's not even totally reflective, is what is the viral load? CMV antigen. They can do that regularly, and I've had patients who are on leukemias or with CMV retinitis, they do regular, maybe one every 2 weeks, they check their viral load. If you see it going up, then warning signals, be careful, anytime now situation. So when it is a non-HIV, unfortunately you have no monitoring parameter besides maybe viral load and an indicator from the attending physician. How do you think of this patient? Is he doing well or not? So not just that, of course the other group of patients will be your rheumatologists who either have your patients on Zelsat or on cyclophosphamide. So these are some of the patients that may also get CMV retinitis. And again, you don't have a fixed parameter. You just well, what do you think? Most of them will say, okay, I'll try to reduce the immunosuppression, and then you just hope lah. When you reduce, you treat, after it becomes quiet, then say, fingers crossed, let's try and stop the anti-CMV. Has it recurred? If you stop, if it hasn't come back, you can't say, all right, fine, end of story, but you still have to continue to monitor them regularly because, as you pointed out, they can recur, and you don't know when.
In these cases, do you once you've gotten the CMVR resolved, do you continue on with a period of maintenance therapy? I mean, it's like almost like blind.
Yeah.
So you give it for what?
A little while, and then discuss with the patient that, right, you seem to be doing well. Your primary physician seems to be decreasing your medicine. He feels that your immune status is reasonably stable. Let's try and stop and see what happens.
Thank you.
Great. I think that's a level of discussion we want, and very good questions. And I think thanks. There are no questions, then we move to Daniel, who is very keen to give his talk, and I can see him warming up. And I think welcome Daniel. Thanks. And he'll be speaking about the diabetic glaucoma.